Hi, thank you for being with us. I was just wondering if you could introduce yourself, please.
Yeah, my name's Charles Heatley. I'm a GP and I'm Clinical Director for Elective Care at Sheffield CCG.
Excellent, thank you. I was hoping you could just tell us a little bit more about the cases model.
Cases is a way we're trying to do things differently in Sheffield for patients who traditionally go to outpatient clinics. So the cases is the 5 letters within it, which is that it's clinically based, it's about patient care, that it consists of assessment of referrals that are made to hospital or specialist clinics to see whether we can make that as fine-tuned and as efficient as possible, or also to see if we can actually make it possible to do as much in the community as we can without people having to travel. The S is for services, so that's things like getting diagnostic tests in the community and getting treatments and other things available in the community again, rather than in hospital clinics. The E is for education, and that's fundamental to this whole process. We want mutual education between specialists and GPs and nurses and the other health professionals in the city, so that actually we work in a much more joined up way, and that GPs particularly get feedback about how the system can work and how they can manage more things in the community in the future. And then the S for support is primarily about how patients can be supported in managing their conditions, and that hopefully will involve a lot more work from voluntary organisations in the third sector.
You mentioned about tests there. What sort of tests do you expect will be done in the community, and whereabouts will they be?
Yeah. Currently, a lot of tests are done in the community, particularly blood tests and tests for infection. We can do more things like ECG tests. We can perhaps do some X-rays and tests that collect information about people. It's much more important to get a full picture of the patient's problem. We're not thinking about big things like MRI scanners or heart scanners in the community. Those sorts of things may be best done in hospitals still. And we're thinking about things that can be done within practices or within local health centres.
So does this mean that we'll be going to hospital less then?
I'd hope so. We know that quite a number of people who find themselves in outpatient clinics could be managed at home with the right support to the GPs and practice teams. So some people just don't need to go at all. But there are plenty of other people where by the time they get to the specialist clinic, if all the right information has been gathered first, whether that's tests, scans, and so on, if that person arrives at the clinic with all that information on the record, then the specialist can make a much better judgment about what to do. And that should mean fewer visits to hospital.
Great. When you talk about cases, is this going to be a physical service? Is it somewhere that we're going to have to go to?
No, I don't see it like that at all. If anything, it's not about building, it's not about making new places. It's about bringing together the different elements of this. So a lot of this work should be done remotely, and hopefully if there's any travel for the patient to do, it's somewhere within their locality, not all the way to the city centre and back and so on. So no, it's not about a new white elephant, it's about all the elements coming together.
So how do you see this being better for patients?
I'd hope it's better for patients because it means that they can get more care from their GP practice and their local health team. It means that if they do have to go to hospital, they make the minimum number of trips and they get it so that every visit counts and makes a difference to their care. So overall, we're just trying to make it much more streamlined for people. And then if they do have an ongoing problem, they're getting much more support so that they can manage their condition themselves with the right help.
And I know people get frustrated about having to repeat the story lots of times to different health professionals. Do you see that cases will help with that at all?
That's a big aim, and we know how frustrating it is for patients to have to tell their stories. So we've worked hard in Sheffield at making sure that, for instance, blood test results are available both to GPs and to specialists in hospitals. And we want to extend that further. We know, because we've asked patients, if they mind about having their GP or electronic patient record shared, and everybody says they thought it was happening anyway. We want to make the right agreements take place between the different providers of care, so that they can do that safely and securely, but so that those stories don't have to be repeated because it's there for the specialist or the GP to see.
And how is this going to be better for clinicians working in the system at the moment, like my GP and my consultant?
One of the problems that's happened, because medicine's become so much more complex and because of the workload of both sides, we haven't had much chance to really communicate with each other effectively. And I think the hope is that through cases there's much more dialogue between specialists and GPs and practice teams, so that we can spread the information, we can understand each other's roles and abilities much more, and have a much more joined up system.
And do you suspect that we might be seeing more consultants coming into the community?
Yeah, I think we would like to see more of consultants in the community. But what I'm not talking about is just moving an outpatient clinic into a community setting, because that's not going to really make a huge difference to the process. It's more about getting that knowledge out into the community, and if that requires the consultant coming to see GPs or see patients, that's maybe the right thing to do.